Hello, hello. This meeting is being recorded. Hello, everyone, and welcome back. Uh, this meeting is being recorded and live and streamed. And today we're going to start a series. It's the first of a series, and we're going to highlight specific profession types that have been key and laid out in the health talent assessment. And these are identified as the most needed or the highest risk of turnover. There's not a perfect way to decide who goes first, and how to group them. And so we kind of put people in different categories. We're doing psychiatric medical professionals, addiction care providers, mental health providers, peer and youth focused providers. During this series, we're going to do a deeper dive into each of the profession types because we want to create a kind of rich understanding for all the council members of what these jobs actually do. They're going to give us best practices on education to training and recruitment and retention. Um, and so today we're going to start with our psychiatric medical providers, and that's specifically psychiatric nurse practitioners and psychiatrists. We have some special guests. Thank you so much. There's no hierarchy here in terms of how we do this and what professions. Everybody matters, and we are really grateful for these folks who are able to pull this together on a tight timeline. Um, After having more conversations with people, it just became clear that people wanted to have deeper understanding of kind of how all of these roles fit together. And so folks were able to pull this together quickly, and we really appreciate it. And then stay tuned for the following meetings as we'll do a deeper dive in each profession. I always want to thank my vice chairs, and I want to thank Clarissa for doing an amazing job. She's a psychiatric nurse practitioner herself, and is really dedicated to community health, and for lending her incredible expertise in building the meeting's agenda. I also want to thank Rachel Pruzak, the director of the State Board of Nursing, for her contributions in the meeting today as well. We're going to go through, we're going to do presentations, and then we're going to ask people, and there'll be questions at the end. And I do want to say, if I mispronounce something, please correct me. I want to, please don't be shy about that, and do it. And it is always welcome. Is it Shaylee Hodgson? Okay.
Yes.
Of the heck, we'll anchor the council in the talent assessment. We'll remind people about what these professions are and why. And then we'll have three presenters that will give us an overview um, from there on education, training requirements, and scope of practice, because that I think is going to get really important for everybody in the room. First, Rachel Pruzek for the Oregon Board of Nursing will talk a little bit of the overview of the psychiatric nurse practitioners, education pathways, scope of practice, and then a step-by-step for the process of becoming the nurse practitioner, which I think is something we need to have. And then afterwards, we're going to have Elizabeth Ross from the medical board will present an overview of psychiatrists, including educational requirements, clinical training, scope of practice, and then the step-by-step for becoming licensed. And then lastly, Neelam Gupta of OHA will present a summary of funding streams and programs that already exist to support the roles in the system. After the presentations, that will kind of create the foundational knowledge. We're going to move into best practices. At that time, we're going to hear from Dr. Neil Folk, the Associate Medical Director of Cascadia Behavioral Health, who also provides psychiatric services to very young adults with early psychosis to ESA. He has decades of experience in hiring, recruiting, retaining, and supervising folks. He also is the assistant director of a nationally recognized public psychiatry training program at OHSU. And then afterwards, we are going to have Ajita Jetlani, the director of child and adolescent psychiatry at OHSU and the director of the Oregon Psychiatric Access Line, will present on best practices in training and education and recruitment and retention of psychiatry. We'll take a 15-minute break. It will maybe go down to 10. We'll see how it goes. And then we will hear from Dr. Daniel Weiner of Road Community Health, who will speak to best practices in family medicine, addiction medicine, and psychopharmacology. Next, we'll have Dr. Tyler Chipman co-director of the Psychiatric Nurse Practitioner Program at OHSU School of Nursing. And then lastly, we will have Dr. Mandy Hudson, Medical Director of Trillium Family Services, Corvallis Campus, who is also Assistant Professor of Psychiatry and Behavioral Health Medicine at Western University Health Services and Chair of the Oregon Wellness Program Executive Committee, who will present on best practices in the psychiatry workforce. Thank you so much, all of you being here today. This is an amazing cast of this is just an amazing group of people. What a cast of characters to have, and we're really looking for. This is a maiden voyage. We're looking forward to it, and let's get started. And so, Sheila, do you want to start from the heck and do a little kind of ground us in the talent assessment and how the need of both filling these positions and keeping people in these positions are important to the work that we're going to do today.
Absolutely. Happy to do that. Taylor, am I sharing or, oh, okay.
Yeah.
Let me get
You have the ability to share screen shortly.
Okay, perfect.
And we always have a backup just in case.
All right. Okay. Can you see the slides? I have all the windows. Okay. Good afternoon, everyone. As previously noted, my name is Shali Hodson, and I'm a policy advisor in the Office of Community Colleges and Workforce Development at the Higher Education Coordinating Commission. And today, before we hear from the experts, I want to share some information to help ground you in the analysis found in the Behavioral Health Talent Assessment for these occupations in psychiatric medicine. This is going to include a few slides on information related to the occupational pathways and education, licensing, et cetera. We'll talk then about projected workforce shortages and share some information about elevated turnover risk in these occupations. Okay, so this slide, which is hard to see and somewhat complicated, is really just an occupational pathway map. And so the talent assessment identified doctoral pathways that lead to occupations, and including psychiatrist, psychiatric nurse practitioner, and as you can see, other occupations that encompass psychology and counseling related pathways. So for today's discussion, we are focusing on the psychiatric pathways of medical degrees and doctoral degrees in nursing. As you know, these occupations require individuals to complete a lengthy and specialized path, which I know we'll hear more about. And this path and time frame can create bottlenecks that worsen shortages and lead to gaps in care. So the chart simply shows the level of education required along with the certifying and licensing board, the credential or license that needs to be obtained and used in practice with these occupations. So now I want to move from the pathway to the pipeline. This table is also in the talent assessment and shows clear evidence of a severe and worsening shortage of psychiatrists in Oregon. This is a gap that is especially pronounced in rural and frontier areas, and the shortage is fueled by things like retirements and provider burnout, maldistribution of professionals across the state, and limited diversity in that psychiatric workforce. And you can see that psychiatric nurse practitioners are not as much of a gap, but they cannot fill the entire gap left by this psychiatrist drought, if you will. And so they are, while an increasingly an important part of the solution, really can't fill that whole gap. Notably, the majority of Oregon counties have fewer than one mental health provider generally per 1,000 residents. And as you think about psychiatrists and psychiatric nurse practitioners, that gets to be an even bigger ratio in that workforce. And so as we see less people potentially going into the pipeline, this of course threatens timely access to services and comprehensive care across the system. Now I would like to go from turnover or from shortages to turnover and what causes turnover. In the behavioral health talent assessment, there was a survey and a survey of professionals and and folks across the spectrum of behavioral health workforce. And the survey shows really an urgent retention challenge in many of these occupations. While you can see that psychiatrists and the psychiatric nurse practitioners report a lower intent to quit in the next month, that was the survey, there is lower than some direct care staff, but still pretty high. There's this really big turnover risk that remains significant due to the small size and central importance of this workforce. So even a single psychiatrist departure in a rural region can leave whole communities without needed care for months. And I know you all know this, but just again, kind of grounding you in what the talent assessment says. And so we see here the same systemic challenges and reasons for this: burnout, administrative burden, compensation, and professional isolation are really at the root of, again, both the shortages and the retention issues. And stating the obvious, making both recruitment and retention equal urgent priorities. And with that, I will turn it over or back, unless there are questions, to the next panel.
And First Lady, if you're having tech issues, let me know and I can hand it over to the next panel.
Okay. Sorry about that. I was having tech issues, but I'm back. Thank you very much. If there are no questions, can we hand it over to Rachel Pruzak?
Absolutely. Let me share my screen, and I know this time I will make sure the whole screen is shared. Hank, what is happening here? Okay, let me go down to Zoom. Did that work? Great. Okay, so first I want to just say thank you to the First Lady for giving a shout out to Clarissa, Carson, and I. I'd say you need a shout out back. I think we're just super excited that anybody wants to elevate psychiatric nurse practitioners and have a highlight on how we serve the community. So just thank you for allowing that. And I'll just start by saying that the last time I presented, I shared how the Oregon State Board of Nursing has removed regulatory barriers to help our certificate holders and licensees meet community demands while staying true to our mission of protecting the public. But today I'm really going to focus on psychiatric mental health nurse practitioners, kind of a 101, who we are, since the council is really looking on ways to recruit and retain, ensure that individuals in the community can access the care they need. So we know that psychiatric mental health nurse practitioners are vital in mental health care, offering essential services and improving community mental health. And the goal of this presentation is to understand who they are and how they are serving for a vulnerable population that the community on this council is centering. So the numbers on this slide show how many nurse practitioners we have licensed in Oregon right now, and how many of those nurse practitioners are psychiatric mental health nurse practitioners. And it's interesting to see these numbers after the other numbers, but I think we'll be able to touch on why there is such a difference there. The other group of numbers that you see on here is from a slide I pulled from the Oregon Health Association, Oregon Health Authority, excuse me, the behavioral health data brief. And I'll make sure that this link goes out to the council. But to be considered on here as a psychiatric nurse practitioner, you had to actually check when you were asked that you serve nurse practitioner who serves psychiatric patients or mental health patients. And then physicians to be considered psychiatry, they had to share that they took care of those with behavioral health. But as you can see, the prescribing clinicians we're focused on today make up a much smaller part of the workforce. So the nurse practitioners are at 9% and physician associates making up 5.8%, compared to the social workers, psychologists, counselors, and therapists making up the 85%. And I think that goes to the point too you mentioned at the beginning, First Lady, about how this isn't about any type of hierarchy. We are a smaller percent, but we really need each other. And I always say I can't do my job without a social worker, counselor. So look forward to hearing about all of those other clinicians as well. So right now, to talk about just definitions and level set. So an advanced practice registered nurse is a registered nurse with advanced education, and they're either master's prepared or doctorate level prepared. So an advanced practice registered nurses can specialize as a nurse practitioner, a certified nurse midwife, or a certified registered nurse anesthetist. And then for this presentation, we'll be focusing on nurse practitioners who focus on clinical specialties such as family, pediatrics, and psychiatry. And this leads us to the scope of practice for nurse practitioners. So while a family, adult, or pediatric nurse practitioner scope of practice includes evaluations, diagnosis, and treatment of some psychiatric disorders like stable anxiety and depression, it's really the psychiatric mental health nurse practitioner scope of practice that includes conducting comprehensive psychiatric evaluations, diagnosing and treatment of psychiatric conditions. So that's including diagnosis like anxiety and depression, but also the much more complex diagnosis like our bipolar disorder, schizophrenia, personality disorder, and ADHD across the lifespan. So the education and training. So obtaining a master's or doctoral degree to become a PMHNP takes up to 3 years of additional training after becoming a bachelor's prepared nurse, which takes often 4 years. So about 7 years total. And I just want to point out that Oregon has only one school offering a PMHNP program, and it's a doctorately prepared program. And due to limited clinical placements, many applicants to OHSU are turned away, and consequently, many rural PMHNPs study out of state, where they share obtaining a master's online can be quicker and at a lower cost. And often the clinical placement is on the student to find their preceptor, and some programs are offering compensation for those preceptors. I wanted to share about a new opportunity that I learned about while doing research for this presentation. So OHSU School of Nursing, in collaboration with Umpqua Community College, has introduced a new admission pathway for students to transition from the bachelor's nursing degree to the doctorately prepared nurse practitioner program starting in 25-26 academic year. So right now it's just kicking off. Eligible UCC students will enter the RN program with the potential for admission into the DNP program. And the first cohort will begin in fall of 2025 upon completing the USCC program, and then enter OHSU DNP program in fall of 2026. I connected with them. It sounds like right now there's one person identified, but this is just something to put on the radar of something moving forward or could potentially really help us out. So getting into some of the challenges. So as we try to solve challenges presented to the council, I really ask that we include ideas to help the PHMP secure clinical placements. So currently, state schools are urging the Oregon State Board of Nursing to regulate clinical placements. However, as the executive director who's been in these conversations, I have researched the issue, and I don't think that the solution lies in more regulation. Instead, I really think it's important for systems to foster academic practice partnerships with support from the state. And I do know that some presenters today will be talking about some innovative solutions for this, and so looking forward to that and then how we kind of put our brains together. And then finally, coming to the certification and credentialing after you graduate the long education process. This competency-based assessment evaluates their entry-level clinical knowledge and skills as PMHNPs. So I wanted to share something interesting that I recently discovered. Oregon is the only state that mandates an advanced practice registered nurse, so the APRN, to be a doctorate level. So typically that decision is made at the university level with kind of dictation from a credentialing service. But I learned there was a discussion in 2019 that started, and it pushed the Board of Nursing in Oregon to mandate it in our rules. And so I wanted you all to know, by identifying this, it will be a conversation the board is having at our November meeting to kind of remove that barrier. I don't think our current program will do anything to reverse how they've set up their programs, but I wanted to elevate that there's a national conversation that started, that we all get our doctorate degrees, our terminal degrees, but it's now kind of thinking, oh, did we create a barrier, especially for our psych NPs and our CNMs? The CNMs are being really loud about this discussion. And moving into, once you're board certified, the high demand for the growing recognition of mental health issues and how PMHMPs can care for them. They work in various settings such as private practice, hospitals, community health centers, and telehealth. And I'm just going to conclude with one more data point before I turn it over to Elizabeth Ross at the medical board. And so I think you can see here another interesting piece is there's actually 132% increase in nurse practitioners since 2018. However, we still don't have the full workforce. So one of the conversations I've been having is about, we have that many licensed, but who may or may not be working because of this conversation of burnout. So how do we prevent the burnout, and how do we look to train more NPs? And I'm really looking forward to that discussion with everyone. But for now, I'm going to kick it over to Elizabeth Ross.
Good afternoon. I am Elizabeth Ross, the Legislative and Policy Analyst at the Oregon Medical Board. I use she, her pronouns. The board's mission is to protect the health, safety, and well-being of Oregon citizens by regulating the practice of medicine in a manner that promotes access to quality care. Today, I'll cover licensure requirements and basic scope of practice for physicians. So that's including psychiatrists, and I also included PAs because, as you saw some of the charts, Rachel showed you that PAs are providing behavioral health care, and that's increasing here in the state. So go to the next slide, please, Rachel. So physicians and PAs must obtain licensure through the Oregon Medical Board to practice and provide care to patients located in Oregon. And during the licensure process, the OMB verifies qualifications and competency. All licensed physicians must complete 4 years of medical school and at least 1 year in an accredited U.S. training program. We often refer to that as an internship. Although not required for licensure, many psychiatrists go on to actually complete 4 years of a psychiatric residency program and may also pursue further training through a fellowship in a specialty area such as child and adolescent psychiatry, forensic psychiatry, addiction medicine, or some other subspecialty area. Applicants also have to pass licensing exams, the United States Medical Licensing Exam, our comprehensive osteopathic medical licensing exam, and then they also must demonstrate competency through training verifications, exam, employment malpractice history, all the things that we look at. Also not required for licensure, many physicians go on to get board certification to demonstrate specialized expertise and commitment to excellence in their field. And they do this through a rigorous exam, training, and ongoing maintenance of that education. OMB does have a process to expedite licensure for physicians who are already practicing in another state. And we also have a special process for military members and their spouses or domestic partners who are relocating here to Oregon. The PA, as I mentioned, we also license a physician associates, PAs here in Oregon, who provide behavioral health care. They have a very similar process to our physicians, except they graduate from a 2-year PA training program, and then they pass a physician assistant national certifying exam. So we can go to the next slide, please. So all licensed physicians, including psychiatrists, have a very broad scope of practice under our Medical Practice Act found in ORS Chapter 677. It's up to the physician to determine the duties within their scope of practice and to obtain applicable training and experience. The scope of practice for physicians is not prescriptively outlined in statute. In addition to psychiatrists, many primary care physicians and also pediatricians provide some level of behavioral health care service to their patients. PAs in Oregon practice under a collaborative agreement with a collaborating physician or employer who employs physicians. PA collaborative practice is indicated by the patient's condition, community standards of care, and that PA's education, training, and experience. Their scope of practice is not outlined or restricted in our statute. Psychiatrists and PAs have full prescriptive authority, but they are expected to prescribe within their scope of practice, within that community standard of care, and adhere to any federal DEA requirements. Importantly, Oregon's scope of practice for both physicians and PAs includes telemedicine provisions, allowing Oregon licensed physicians and PAs to provide remote care while maintaining the same standard of care as an in-person treatment would. This allows both in-state and out-of-state psychiatrists and PAs to provide behavioral health care to underserved populations across our state's diverse geography. And then we have about 21,600 active licensed physicians here in the state and about 3,400 PAs that are actively practicing. Physicians can self-report to us a specialty. It's not required. So we have about 1,300 that have reported some kind of specialty in psychiatry. And interestingly, of the 1,300, 300 of them hold that we call this telemedicine status, which means they're actually outside the state of Oregon, but they are providing care to patients located in Oregon with that status. PAs do not report a specialty, so don't have information on that. So thank you.
Great job. Great job. Before, great job. I just want, can I ask a clarifying question really quickly? Uh, Dr. Pruzak, did I hear you correctly in that the psychiatric nurse practitioners have to find their own practicum?
So if you are at the
Okay.
if you're at the program at OHSU, the one in-state program, they work to find you clinical placement. And I know one of our presentations today is going to be about a grant so that it can expand into the rural area. But many of the rural nurses who want to go on to become psych NPs do end up partnering and finding their own and going to an out-of-state school.
Okay. I'm just asking is as we're doing these presentations, that would be an interesting thing to know for each one is if they get help to finding their placement or practicum through their institution, or if that's something they do on their own. I imagine in each discipline it might be different, but that was just a good point of clarification.
And if I could add one other thing, the stress point that I mentioned, the conversation that I mentioned, where there is in-state schools wanting us to regulate, it is all about the stress over clinical placement and not having enough. And then if out-of-state schools are using the clinical placements, the impact of that, but it's actually Oregonians training to care for Oregonians who couldn't get into their program because it's limited and go somewhere else. So it's really complicated, but it's one that I really hope that we can figure out.
Thank you. And thank you, Elizabeth. Great job. Okay, next we are gonna move into more best practice. Do we have, oh, let me make sure I have this right. Oh, okay. Am I now, I just, let me make sure I'm doing this right. Am I now handing this over to Neelam Gupta from the Oregon Health Authority? I was about to skip ahead. Thank you. Whew. This is still in the best practice for psychiatric nurse practitioners. Thank you.
Great. Thank you. I'm just going to give me a moment to share my screen. So nice to be with you today. My name is Neelam Gupta, she, her pronouns. I'm the Director of Clinical Supports, Integration, and Workforce at the Oregon Health Authority. I feel honored to be in the presence of all these wonderful speakers. I'm going to be speaking about some OHA managed federal and state financial incentives that support psychiatrists, psychiatric mental health nurse practitioners, as well as I didn't specify it, but they also do support physician associates. And so you'll see here that there is some color coding that, you know, some of these incentives are state financial incentives. Others are federal financial incentives through the Federal Health Resources and Services Administration, or HRSA, and some that are in yellow are federal non-financial resources. And so the first, and if you look here vertically, they're categorized according to grants, loan repayment, scholarships, and then non-financial incentives. So the grants that OHA offers, we have the Healthy Oregon Workforce Training Opportunity Grant Program, or HOW-TO, that provides up to 3-year grants to workforce development projects that have identified healthcare workforce shortages and increase work diversity. We also recognize that we want to impact young people, so we have a career pathways incentive and particularly to provide career exposure and mentorship and opportunities to earn certifications for middle and high school students. In terms of loan repayment, there is, we have both a state-funded loan repayment program, and then through the federal government, we facilitate several different loan repayment programs. One known as Nurse Corps, another around faculty, because we know that faculty don't get paid as much as practicing professionals out in the field. There's also a federal loan repayment program, rural loan repayment program, and the one around substance use disorder professionals. We also offer a series of scholarships through Oregon Health and Science University. We partner with them and provide funding for the Scholars for Healthy Oregon initiative, or SHOE program that provides scholarships to 4 clinical programs. There's also then some federal programs, the Nurse Corps scholarships, Students to Service scholarships, and then another scholarship program. We also provide a non-financial federal incentive. As the state primary care office, we administer the J1 physician visa waiver program, which we get 30 slots each year to place international medical graduates who completed residency here in the US in a medically underserved community in exchange for a service commitment. And most of these incentives do come with a service commitment at a qualifying practice site. So I wanted to provide some examples of these OHA managed incentives for behavioral health workforce. And most of these incentives go towards serving Medicaid and Medicare patients. So you saw several National Health Service Corps, or NHSC, incentives that are federal ones. It currently offers scholarships and loan repayment to 59 nurse practitioners in mental health specialties and 10 physicians in mental health specialties, which we presume are psychiatrists. And then the J1 physician visa waiver program has placed 16 psychiatrists who are international medical graduates, all of whom continue to practice in Oregon beyond the service commitment period. The HOW-TO grant program also has funded a distance education psychiatric mental health nurse practitioner program to increase licensed prescribers in Eastern Oregon. And then the healthcare provider incentive program offers loan repayment to 7 psychiatric mental health nurse practitioners. And thank you so much for having me today.
Great job. Okay, that will conclude our psychiatric nurse practitioner portion. I want to say thank you. You know, psychiatric nurse practitioners do incredibly important prescribing work in community mental health, particularly with the Medicaid population. And so I wanted to thank everybody for that. And then we're going to move into our psychiatric practitioner portion of it with Dr. Neil Folk, who is the associate medical director at Cascadia Health, who has been in community mental health for a really long time, who knows a lot about. There are people who stay in this work. There are ways to stay in this work, and we are just so happy to have you here today. Will you take it away, Dr. Folk?
I appreciate that. Thank you so much. And thank you again for inviting me to speak to this really important topic, as well as to everyone who's working on this on a state level. We really appreciate all your help and support. As Amy said, I'm the Associate Medical Director at Cascadia, which is a large health provider, community mental health provider, primarily in Portland. I've been here 22 years. I've also been working for 16 years as the doctor with the ESA program in Multnomah County, another thing that I love to do. So I'm going to be switching gears, I guess, into how to retain people in these community settings. And let me see if I can get things shared right here and get the slideshow up and running. Folks can see the slides, I hope. Yes? Awesome. So a lot to say in very little time. I'm sure many of you are familiar with these strategies that have been enacted, and I'm glad to say many of these have been enacted in my experience here in Multnomah County in Oregon, as far as system changes to address workforce shortages, especially in particular for medical staff. But I want to talk more today about what we do at, let's say, a clinic level, an agency level, as far as trying to address the workforce shortages. And when you're talking about health providers, MDs, DOs, physician assistant, nurse practitioners, some people call them prescribing staff. I prefer medical staff. These are the three cores of what we do to try to attract and retain staff. Educational interventions, primarily with students who are rotating with us, or outreach to the community, how we recruit medical staff, and how we work to retain medical staff. So I'll go through each of these one by one. As far as educational things, one thing I think is more societal than talking to students or talking to other practitioners, it's just raising the awareness in the community that there is a neurobiologic basis to a lot of mental health issues, which again is where medical providers can enter in the interventions, as I list a little below, not just in prescribing medications, but also in doing therapy. Part of that also is recognizing, again, at a more of a general public level, that there are effective treatments for these neurobiologic causes of mental health issues. Again, those neurobiological factors can be affected not through medications alone, but also through therapy. A no-brainer when I was looking at some of the literature on how working with students can entice people into going into the behavioral health fields. You give people a good training rotation, they get enthused by it and want to go into that field. And there's lots of things that could be done in medical schools, in NP schools, to encourage people to, have high quality rotations. But again, that needs some support, both of the institutions and the community around. Some people reach into undergraduate arenas and say, let's try to recruit people who are coming from, if you will, humanistic majors, psychology being the no-brainer for mental health. And they have found that people who major in psychology, I'm biased, me being one of them years ago, end up being gravitating towards the mental health field when they go to a medical professional school. It's really interesting if you look at medical students, at least, of what they think they will go into, what field, what specialty when they enter medical school. Psychiatry has the highest rate of people who stick with their initial intention. 50% of medical students entering medical school who say, I'm going to be a psychiatrist, become a psychiatrist when they graduate. So again, reaching into fields where people might have that interest up front can pay off dividends when they graduate 4 years later. If you have time and interest, the Brits are doing some really interesting stuff as far as intervening at a pre-training level, if you will. You can look at the article I've cited on top here. Two of the ones they discuss in depth is having sort of a real-time Q&A outreach by medical providers of different fields to high school students to have discussions of what is a career like in surgery? What is a career like in neurology? What's a career like in psychiatry? To sort of get that spark early in someone's career development so that they can think of becoming a nurse practitioner or a doc who goes into behavioral health. They also have this real cool concept of living libraries. Just like you borrow a book from a library, you can borrow a medical professional from the library who volunteers to sit down for 20, 30 minutes and not talk to a group like in that first example, but to an individual to answer career questions. That would be a really cool program to have in Oregon. I also like there's some integrated approaches. Medical schools are starting to teach how psychiatric issues influence primary care or surgery or hematology or oncology, just to make people recognize, oh, there's really cool stuff that's going on in psychiatry that isn't just mental health alone. One other thing that statistically plays out well is having people in undergraduate education and medical students, I'm sure it's true for PMHNP students as well, seeing themselves in leadership positions. So having psychiatrists or PMHNPs leading organizations, leading the cause, listening to what is important for the medical providers to bring that into the whole of the agency, which sort of transitions into recruitment. How do we get the pipelines to bring people into our agencies? And having that visual medical leader is really important, but it starts well before then. Part of it is encouraging our staff to work with students. It's quite rewarding. I've been working with students pretty much every year in the 20 plus, 30 plus years I've been doing psychiatry. The big thing I hear from our providers at Cascadia is, well, if I'm going to work with a student, I need the time to work with a student. So making sure that we have protected time, which is somewhat antagonistic in a way to the goals of an agency at times, because as I'll talk in a future slide, we can bill a lot for our services, and taking us offline to provide teaching reduces that revenue, but I think it pays dividends on the back end. It also helps if we as an agency or the schools themselves can give a stipend to the folks that are mentoring the students. And that's going to get more people, again, into these high quality, good rotations that will hopefully spark their interest and keep them in the behavioral health field. The nice thing about having students at an agency is they get to know the agency during the year, the 6 months, whatever they're working with us, so they can make a good informed decision about this will be a good place for me to work, or nah, this is not the place for me, which again will feed into retention because they know they're entering a place they want to work. The benefit to the agency is these graduates move into an employee role. They don't have a lot of orientation needs, so the orientation goes quick. The learning curve to learn the system is not as steep, so people can get more productive more quickly, feel better all around about how things are going. And when you retain people, which we'll get to the retention issue in a minute, that helps recruitment because people want to go somewhere they know that people are happy. Not unique to medical providers, but very important nonetheless to medical providers. When I talk to the folks at Cascadia that we're trying to recruit to join us, these are the issues that they bring up over and over again. And number one, and I would say number two and number three is loan repayment. I have a friend who is a neurologist, and as she says, her loan repayments are like having a mortgage to pay every month on a really wonderful home that she never gets to visit, because those loan repayments go on for decades and they are a lot of money. So folks that are just coming out of school are looking for those clinics that will give them some element of loan repayment. HPSA, HPSA scores are, health provider scarcity areas. So every agency has a score of how underserved, if you will, the area is. And the more underserved, the higher the HPSA score, the higher the score, the more attractive it is to applicants because there's more opportunities to get the loans paid off if they give a certain amount of service. New people that are looking to join into behavioral health, the medical providers are looking for a flexible schedule that gives them a good work-life balance. I would also argue psychiatry is one of the specialties where it's easier to achieve that. Again, part of the reason I've been doing this 30 plus years. Again, retention and recruitment go hand in hand because one thing these new employees are looking for are seasoned mentors who can help them figure out how to do things well. So the more you retain people, the easier it is to recruit new people. New grads are also primarily, I won't say primarily, but often looking at telehealth or hybrid work environment opportunities. I think the early years of the pandemic, when we moved to telehealth, brought up a lot of advantages for folks, and they'd like to retain those advantages if they can. And of course, one of the big core things that attracts people to work at an agency like Cascadia and elsewhere, what is the mission of the agency? Does it dovetail with their outlook of how they want to practice and who they want to work with? Moving real quick to retention, and then I can get to some questions if you have any. Burnout is common in community health, and I'd argue especially among prescribing medical staff. Why is that? Real briefly, medical staff usually bring in, as I mentioned, a lot of money. We get high reimbursement rates for activity, so there's a lot of pressure to perform all those activities to bring in more money. We also happen to be probably the highest paid employees in an agency, and salary is usually the largest expense for an agency. So we are really expensive, but we're really powerful because we can bring in a lot of money for our billable activities. So there's this pressure to get your money back, if you will, as an agency and keep the medical staff working hard to bring in that money. When you add into that fact that medical staff often feel compelled to sacrifice themselves, give of themselves to help the population they're working with, especially in community health, we buy into that. We want to work hard, maybe too hard sometimes. And you can tell this is just a formula for overworking, poor self-care, burnout. So retention, well, I'll get to how to avoid the burnout in a minute, but why is retention important? Replacing a medical employee in a health agency usually costs somewhere between 50 and 200% of that position's salary. Turnover is expensive. Recruiting is expensive. Retention saves money. When you have new employees come in, as I mentioned earlier, there's that learning curve that they're less productive and maybe providing less quality of care. Retaining employees eliminates those problems. Agencies, as I mentioned earlier, with high retention rates also attract more employees because people want to work where they're happy. It's a no-brainer. So what's the best way of retaining prescribing staff in a community mental health or behavioral health system? The big one is preventing what some have called the giant in the closet syndrome. As I've mentioned, doctors, nurse practitioners, PAs, we wield a lot of power. We can prescribe medications. That's powerful stuff. We can sign forms that open doorways to accommodations at school, disability issues, etc. So we have all this power, but because we can be expensive, a lot of agencies try to minimize our presence, and you end up being the giant in the closet who has all this power but doesn't get to do anything else and is kept in that limited role. That is a prescription for burnout for medical staff. The way around that, integrate staff into the teams. Let them work with other people instead of work in isolation. Transdisciplinary teams, the best option, batting things off each other from different disciplines. Expand the role beyond prescribing and signing forms to administrative roles, leadership roles. And let me tell you, our medical staff so appreciates at Cascadia that we have medical leadership that's listened to, that has input into the direction of the agency. Again, that will raise morale of medical staff. The other thing our medical staff ask for is ongoing education and support, be that internal trainings we provide for each other, access to medical resources so we can look things up, or even stipends to go to conferences or something outside of our agency. The other big issue that we've learned over the years, and boy, it pays dividends, is get a workplace culture that promotes self-care. We preach self-care to our clients and patients all the time. We got to practice it ourselves. We had a CFO a couple years ago who I loved when she changed my perspective on this and said, no, we don't want people carrying over PTO, paid time off, at the end of the year. We want them using all their PTO because then they're well-rested. Well-rested employees are happier. Well-rested employees are more productive. That's a lot in a little bit of time, but I wanted to leave time for questions. Again, I appreciate the opportunity and the invitation to be here. What questions do you all have? Stunned silence. Julie, go ahead.
I actually have a question for Clarissa, but it's related to what you presented. I was struck by the data we heard in the first presentation about 73% of psychiatric nurse practitioners are saying they're going to quit. Clarissa, from your perspective, in your colleagues' perspective, if you had to name the number one burnout issue for you, the number one, what would it be?
go ahead. My colleague.
Oh, you want me to answer?
Sure. Go. She's asking both of us. I want to hear you first. I want to see if we can match.
I think there would be two issues, which I think one would be systemic, which would be paperwork, and not necessarily documentation, but things like prior authorizations for medications, forms that need to be filled out to be allowed access to certain treatments, etc. Not to be too facetious, but I think there's an appropriate attitude of, hey, I know what I'm doing, let me do my job. And when you're not allowed to do that, it's discouraging, and it's, oh, other words I could think of, but they're not coming to mind right now. It just ain't fun. And I think the second thing is just being overworked and not getting the time to do the paperwork, do the training with students. Again, there's that pressure to perform, to bill, but there's a lot that can be done to streamline the system of care if you're given unbillable time to make phone calls, consult with staff, etc. Clarissa, what would you add?
I would echo charting. Number one, charting. I stayed here until 8 o'clock when I had to go home and read to my child last night, charting, and I still have hours to do. So the charting, we have to find solutions to help with the charting. Panel size, although I'm very blessed here at Rogue Community Health, actually my boss, Dr. Weiner, limits, he's promised us quality of care by giving 30-minute follow-ups and 1 hour new patient appointments. And that should be our standard, honestly. There's places that are turning and burning. They're doing 15, 20-minute med follow-ups. No way. No way. I think that also, and that builds to a big panel size. When I say panel size, when you have 4 patients an hour, my gosh, you're seeing, a lot of patients. And I think, yeah, the quality of life aspect, insurances have become very obstructive on medical providers. And as my colleague said, all of the paperwork involved with it. But, there's also mental health, quality of life, and really, you made a great point that helpers want to help, and sometimes we overlook ourselves. I just heard this week from a provider here at Rogue, how they don't necessarily think about themselves, but they're here to give constantly, and we really do have to support and reinforce that culture of care, which includes us. Thank you.
Taylor, do I see your hand up? That's always a sign.
Yes, Shira had her hand first, but we
Okay, Shira gets
are
to
at
go.
time.
I just wanted to ask, I think one of my biggest challenges with supporting our LMPs is knowing who's the right staff person to be their support person. What's the right credential? Who do you want to have next to you, and what's most critical? My telehealth, most of my providers are telehealth. And I have an LMP support specialist. She's not currently an MA. She probably should be, but they're hard to find. And so, what are the deal breakers for you guys if you don't have the right person in your corner?
I think one of the tough issues, like for example, at the ESA team where I'm working actually right now, we have a client who said, I would work better with a female provider. We did not have a female provider to give that individual. So they have a male provider, and that's causing a barrier. So the moral of the story is, if you can give the client what works well for them, that's the best option. In fact, if you look at all the studies on therapy, the number one factor that says, does someone get better in therapy, is what's the relationship like with their therapist. So having a wide variety of people, a wide variety of perspectives, a wide variety of cultures is your best bet. And I can recognize in some smaller areas or smaller agencies that might be tough to pull off. And when that happens, we acknowledge it up front and say, we are sorry, here's the issue, and try to work with the client to see what we can do given the tools we have. I don't know if anyone else has another answer.
Shira, were you talking peer to peer? Like what do we need to feel supported as providers?
That's
Yeah.
my district nurse practititioners and my MDs. I have someone on staff who supports them, right, with refill requests and like
Okay.
kind of thing. And it always feels like maybe they are not getting enough from their support staff. And so I'm just wondering, what do you feel like you need from support staff to make your jobs easier to manage?
Apologies, I went in a different direction. Go for it,
No
Clarissa.
problem.
Oh gosh. I'm not sure I'm the right person to ask. But I would say that my MAs are trained specifically for psych, which makes it very helpful. I think from my support staff, it is nice if they understand like my credentialing and my scope of practice. I think Dr. Weiner does a really nice job of speaking to our like HR or whatever, so there we have that crossover with we have, really great medical leadership. If that's not in place to help our support staff understand, um, I think that my colleague had a slide in the slide deck that really said something key, which is that medical professionals want to be part of the decision making. And I think that that encompasses maybe it's speaking to your question. I don't know, Shira.
If I can add on
Oh.
real quickly, our staff at Cascadia has been begging for MAs for years. We finally have MAs on the behavioral health side. Huge difference. An example of something I dealt with personally this morning. One of my clients said, I didn't restart the medications you prescribed because there's no refills. I look back in the system and the EMR says there's at least one refill left. Someone had to call the pharmacy and figure it all out. Given the support that I had available, I had to make those phone calls. Now, I don't mind doing that, but it is certainly more efficient if you have an MA doing that. So people who can take over that level of task would be fantastic.
So MAs need some highlighting in this work, I feel like, because they are hard to find.
Yeah.
Incredibly. And part of the problem we've run into at Cascadia is the pay, to be honest. We've had people we had someone who interviewed once who looked out the window and said, you see that McDonald's across the street? I could make just as much money there flipping burgers and it's going to be less intense. You can't argue with that. That's, I think, one of our big issues in recruiting MAs.
Wow. We are going to have to keep moving. Thank you so much, Dr. Falk. That was it.
My pleasure. Thank you again for inviting me.
And First Lady, you are muted.
Oh, wow. It's like you were responding perfectly. Thank you so much. We need to keep moving. We really I appreciate the presentation. And we're going to continue to move on. Thank you so much. Next, we have Dr. Ajit Jetmalani, I'm sorry, for OHSU.
Yes, hello, thank you. Is my screen sharing now?
It is.
And is it now full screen?
It is.
Great, okay. Yeah, I'm Ajit Jetmalani. I'm a child analysis psychiatrist, professor of psychiatry at OHSU. My first job in mental health was 50 years ago at the Oregon State Hospital as an aide in the activity therapies department. So I've been at this for a very long time. Currently, I lead our child psychiatry program. I was a consultant to Oregon Health Authority for 18 years, and I've worked in every mental health setting in Oregon, type of setting in Oregon. So I was asked to personalize this a little bit and describe why I've stayed in it for so darn long. And so I'll first give a few general comments and then get to that. And of course, best practices really are guided by the ACGME, which is the national accreditation that accredits all residency programs in the country. And OHSU residency programs are very highly regarded, very prominent programs across the nation. And so we attract a lot of people. We get med students applying all over the country to our program. The the program, the process itself, we heard about that a little bit, but there's 4 years of college and pre-medical studies. The average age of entry into medical school is 24. 4 years of residency for adult psychiatry, or it could be 3 to 4 years of adult and 2 years of child psychiatry training. And so that's 12 years after high school or 8 years after college of 8 or 9 years after college. So a person's about 32 years old when they get done with all this. And on average, we're north of 200,000 when you include the cost of undergraduate. So 250 is a very common number, $300,000. And the average age of retirement is 66. I'm sorry, but I'm very suspicious of the comment that 76% of child or psychiatrists are planning to quit in the next month. I think there's some data glitch there, but that doesn't mean that people are happy and that people are not burnt out. There's a lot of burnout, a lot of struggle, and life is hard for many physicians. So we are very sought after, I think, because we can spend time with our patients and get to know them on a human level, and that's a big driver. When we get a trainee in our program, which is very psychotherapy focused, we hear from people who want to learn how to do psychotherapy and spend time with their patients. That's a big driver for why they come into psychiatry. In 2024, 200 medical students in the United States couldn't find a place to train. And part of that is because the US federal formula lumped psychiatry into specialty rather than primary care. And so specialty things like surgery, dermatology, et cetera, were reduced and primary care was increased in terms of ratios of spots available funded by Medicare. And the thing is that that was a mistake long ago, and we're paying the price of that. Recent legislation also federally limits the amount of money that you can borrow to $200,000 a year. So you can see a big gap there of how much it costs and how much you can borrow. We increased our residency size thanks to Governor Kotek's support for OHSU to use state funds for behavioral health training and service expansion. So we're now at 12 residents a year. It's a 4-year program, so that's 48 residents in our program. We interview 10 applicants for every spot, and there's hundreds of others who don't get an interview. So I'm telling you, there's people who want to do this work, but they are not getting spots. We did work very hard with St. Charles. They worked hard with us to design a program for residency training. You've seen the maps. Providers, physicians are in the corridor, I-5 corridor, right? We all know that. We tried to create a program at St. Charles, but the financial headwinds to hospitals created an indefinite delay of the initiative, which was really far along. So that was very sad. On the positive side, Care Oregon initially, and then now OHA had a policy option package the legislature approved. So we increased our fellowship training from 3 to 5 a year. That's quite a large increase, first time in 30 years. So now we have 10 child psychiatrists, 5 each year. And then OHSU also supported Governor Kotek's interest in increasing training for behavioral health nurse practitioners. We heard the challenge, which is that there are not enough specific spots to train. And then if you do find a spot, sometimes it's not exactly where you want to work or not enough to get you prepared for where you want to work. So we are expanding training slots in general at OHSU. And then we're creating a postdoctoral training opportunity at Unity in child psychiatry so that people really are ready for very acute, complex patient care, which is frankly where nurse practitioners end up. Because there aren't enough psychiatrists, and nurse practitioners bring a lot of skills and knowledge, they end up in very hard situations where they feel overwhelmed oftentimes. They do call our Oregon Psychiatric Access Line frequently, which is a wonderful experience where providers in the community can call a child psychiatrist or an adult psychiatrist and get advice and support for their care. Okay, one of my pet peeves is the term prescriber. Let me describe what a psychiatrist is. And I bet a nurse practitioner and other clinicians would say the same thing. Psychiatrists are physicians. We have deep knowledge about human development, disease, and resilience factors. We perform biopsychosocial. We think about the whole picture in our evaluations and treatment. We think from a systems perspective. We've witnessed the profound influence of social determinants of health and the power of trauma-informed care, as well as the capacity for people to heal. And we are trained in psychotherapy, and we believe in lifelong learning and teaching as central to our identity. Now, compare that description of a psychiatrist to prescriber, one who hands out medicine. Is that a good term for people who have this knowledge base? And is it reflecting how much time somebody should take to treat a whole person and understand their needs from a holistic perspective and have that person feel like they're being seen as a human being and actually adhere to the recommendations that are made in that appointment? No, you cannot do that in a short appointment. It is actually a waste of resource to do it that way. Okay, so I've been at this for a long time, like I said. Here are the 4 core elements that have kept me in my work. I am deeply motivated by attachment to other human beings, my relationship with others, and how that empowers me to tolerate distress, frustration, and the pain of living one's life, but also practicing medicine in a resource poor, sometimes resource-free environment. Okay. My other thing that helps me feel like I want to come to my job is that I have the knowledge and skills I need to feel effective in my work. And I feel I have agency. I can make a difference where I work. Now that I'm old and been doing this for a long time, I have agency on a system level, but I didn't have that when I was young. But I felt agency in other ways I'm going to describe. And then I've always felt that acknowledging others and appreciating others, and then having that reciprocal experience of people doing the same for me also makes me feel like I want to come to my job. So I think these are 4 core areas. And with attachment, I need enough time to spend with my patients. If you'll accept me for saying this, I love my patients. I love my colleagues. I need to have enough time to form those relationships so they feel that on enough of a degree to feel motivated that somebody is really there to help them heal or help them collaborate with my colleagues. Reflective supervision is a powerful tool. In psychoanalysis, we call that transference, countertransference. People don't like that terminology. It's old school. Well, reflective supervision is the same thing. It's just with a different name, which is let me talk to somebody who has more experience than I do. Have that person help me reflect on why I felt a certain way, and then help me learn how to navigate those emotions. And both of us, through our collaboration, will improve each other's perspective. And then doing it regularly creates a systemic improvement in the culture of that agency and in ourselves. So 0 to 3 has a wonderful description of that if you want to look at it. The other thing is a framework. Collaborative problem solving is a framework that says don't judge people, but be curious about them and think about why they're struggling. I learned that early on, not with CPS, but this is a framework that fits with my perspective. But I know if I approach others that way and they approach me that way, we collaborate towards a solution. We don't tear each other down and have judgment about each other. So that's kept me in the workplace, healthy workplace. And then working with youth and families, I was on CSAC, the Children's System Advisory Council, for 10 years. I'm telling you, being able to work with people with lived experience is the most powerful experience a clinician can have. It's great, especially when it's a collaboration. And I apologize for putting it this way, but if the process is a place that you go and you hear about terrible things that happen to people, and that's the only thing that happens, that's not really a collaboration. It's necessary in the beginning, but it has to move forward to collaborating into solution-focused practices. I feel we are stuck in some settings in the sharing the trauma and not really getting the solution. So I just want to say that out loud. Knowledge and skills. I'm going to go quickly. I know there's not much time, but lifelong learning with others in a supervision practice is incredibly powerful. And teaching is learning. So whenever I teach, I learn. Whenever I teach, I learn. When I had teachers and mentors who I cared about deeply, they took their lives in terms of the framework of their life and their knowledge base. They gave it to me. I absorbed that, translated it into the person that I am, and then I shared it with the next person who I trained later, right? That is a virtuous cycle of passing down knowledge, and that is a relational experience that causes us to have resilience in the face of a lot of stress. Other elements that maybe you can just read on your own, but journal clubs, learning collaboratives, things that are not that expensive, we can do right now with not a lot of money if we invest the time. And as Neil said, acknowledge that if we take a little bit more time, do a little bit fewer billings, we retain people who don't leave. It works out in the end if we run an agency that way. Okay, almost done. I've had the opportunity for large scale advocacy, but agency can happen in other ways. It can happen by doing something called a PDSA cycle, meaning evaluate a challenge that we all share together in an agency setting or a setting of healthcare. So everybody involved says, okay, you know what, we notice this is happening on a repeated basis. Let's address this. What's the problem? Okay, let's measure the problem. Then let's implement a strategy, and let's measure the outcome of that, and then do it again and keep that. That's a virtuous cycle of continuous quality improvement. That's very different than having an organization ream us for a mistake and punish people for an error in the daily practice. Okay, you can do a PDSA cycle and build everybody's sense of agency and excitement about improvement, or you can run everybody down and want them to quit by saying, God, you really screwed up. You shouldn't have screwed up, and you're going to be punished for that action. And you know that I was involved in legislation related to this that didn't get through this year. Okay, and then just to finish, I mean, intentional effort to recognize individuals and collectively as groups, it takes effort and it's hard to do, but gosh, the payoff is huge. And that's when I've felt that people took the time to think about me, it made me feel special enough to want to show up and that somebody cares about me. Those are basic human needs. And I'm going to, these are just a couple, this is the last slide. We could think about how do we try again to create a rural training program, and what are the barriers to not having succeeded there, because we really need them. Training in the site that people may work later is really powerful. The second bullet we've already talked about. And then there's a collaborative care model in primary care that really utilizes physician expertise to address a large population of patients very effectively and in a cost-effective way. Okay, that's it.
I love it. Thank you so much. Thank you so much. That was fantastic. I really appreciate it. We are not going to be able, we are running behind on time, so we are not going to be able to take questions, but I want to encourage people, if you have more specific questions, to please email them to Chad. We were able to cover quite a bit. We really appreciate it. And then I want people to just have a break so they can drink water or whatever they need. But if we could keep it to 5 minutes, so we can hear from more folks. And so let's see, what time is it now? It is 3:14, so that would be 3:19.
Let's do it.
Let's do it. Please turn off your video, but stay in the Zoom. Thanks so much. Okay. Thank you everyone for being so timely. It is hard to do, to go and then come back, but thank you for everybody always being so on time. I think now it is Dr. Dan Weiner from Rogue Community Health. It looks like it was Dan. Will now present. And I apologize. I said that we were wrapping up the psychiatric nurse practitioner and psychiatrist. That's not true. We're talking about them interchangeably. My bad. We were done with the psychiatric nurse practitioners presenting, but not with the topic. And so with that, Dr. Weiner, can you take it away?
Sure, thanks. And I'll just say I was only sort of aware I was going to be speaking to you all a couple days ago. I have no slides. You'll just have to look at my mug and suffer through that during.
We are
during
grateful
this.
you are here.
But I did put some words on paper so I could keep myself a little bit organized. I'll be pretty brief. But just so everyone knows, I'm Dan Weiner. I serve as the Chief Medical Officer for Rogue Community Health down in Southern Oregon, and I'm a practicing physician working in an FQHC in Southern Oregon, seeing patients several days a week. My board certifications are in family medicine and addiction medicine, and I hold a master psychopharmacologist's certificate from Neuroscience Educational Institute, which, to be clear, is not a board certification, as such thing doesn't exist as a fellowship or other training without going through a psychiatry residency. So it's not an option available for primary care physicians for advanced training, which is where we'll get to eventually. So I've worked in either tribal health or community health for my entire career, and despite what the data would suggest, I'm not burned out at all. I love my job, and I don't see stopping it anytime soon. So after completing my undergraduate work in psychology, which I think you heard that theme earlier, prior to going to medical school, I worked as an activities therapist with children in a residential acute diagnostic treatment center. My primary mentor during my medical training was a psychiatrist and neurologist who just drilled me daily on psychopharmacology incessantly. And he encouraged me to do either psych or neuro. He wanted me to join his practice. And much to his disappointment, that just wasn't where my heart was. I wanted the breadth of care we could provide in a primary care setting, and more specifically in the safety net. I always felt we could deliver, we could achieve the best outcomes with a fully integrated or wraparound type care delivery model. And as you all know, there's a high degree of psychiatric comorbidities in our safety net populations. So I've spent the past 20 plus years delivering complex psychopharmacologic care alongside substance use and primary care to my patients in a primary care setting. I've also dedicated much of my efforts to educating, upskilling, and encouraging other primary care providers to do the same, with varying degrees of success, unfortunately. As you may know, there are a few fellowship training opportunities for family medicine docs, OB, sports med, lifestyle med, geriatrics, or occupational medicine, but not the wide array of subspecialties that internal medicine docs have available to them, and no pathway to sort of additional psychiatric training other than engaging in the 4-year psychiatric residency program. Full start, apply, try to get in, that's it. So abandon practice and go on and start over again effectively in residency training. Psychiatry training in medical schools, typically about 40 to 60 unit hours for your entire medical school training. Varying degrees of structure for clinical rotations during medical school, maybe a 4-week rotation, maybe it's inpatient, maybe it's ambulatory, maybe it's good, maybe it's not. And there's not much additional training once you go into a family medicine residency program. In fact, when I was a resident, I did a lot of the education for my fellow residents in psychopharmacology. So it should not be a surprise that many, if not most, family medicine physicians don't feel adequately prepared to deliver high quality psychiatric care to patients with complex psychiatric conditions. Sure, they're going to feel comfortable with a little, run-of-the-mill depression or anxiety, maybe. but are they really catching some of the underlying more complex medical conditions that treating those as simple depression or anxiety may miss or overlook or actually lead to increased complications? So PAs and nurse practitioners, primary care PAs and nurse practitioners, we're not talking about psychiatric nurse practitioners in this, they have a shorter training window, so they receive even less training in the primary care fields. So this is concerning, as although the data sets vary, somewhere between 60 and 80% of patients with mental health concerns first present to their primary care provider. Most remain managed by them in the primary care setting, either because of comfort or because of lack of access. So that's where they're getting managed. Shouldn't we train them? So I have a vision, had it for many years, decades, expanding access to high quality psychiatric care within the primary care setting that will allow providers to remain in practice. That's the key, to remain in practice while receiving structured training and support as they grow their skills. So it's a primary care psychiatry fellowship. And this program could meet the needs of our patients while also improving comfort and job satisfaction for PCPs. You know, we were talking about burnout a little bit ago. If you're a primary care provider seeing a high volume of patients with psychiatric illness that you can't address, not to mention social determinants of health that you have even less ability to address, you're going to burn out quick. We give them the tools so they can deliver high quality care, meet the needs of their patients, high efficacy care to their patients with good outcomes. It's going to reduce burnout. It's rewarding. It's energizing. So the original concept I developed it about, I don't know, 15 or 20 years ago. I've presented it to a number of locations. Really was focused on family medicine physicians, but as the healthcare workforce has shifted over the years, I could see how this model easily could include family practice or primary care PAs and FMPs. The curriculum could be the same regardless of their base licensure. So training side by side, really, quite frankly, why not? It would include a designated amount of educational hours with a specific curriculum that was a combination of sort of online modules, didactics. You do it where you did a weekend, a quarter up at whatever, but you had online modules, reading. I mean, there's all sorts of approaches for training now. I'll just tell you, Neuroscience Educational Institute and Stephen Stahl is absolutely a master at creating unique training opportunities that reach into the home. It would also have to include some sort of a clinical experience as well, with set numbers of hours required. Now, the trick there, as you've heard already, is there aren't a ton of access points for that. So what could that look like and how could we create? So if you look at PA certificate of additional qualifications, they have a structure for that where someone who's familiar with the care and overseeing them signs off and says, I have been involved with their care for X amount of hours, and they have an understanding and a level of experience. So you could create some pathways, combination or hybrid pathway, such as that. Obviously, there would need to be some sort of an examination to demonstrate a knowledge set that was consistent with the high quality evidence-based care. My expectation is not that these trained fellows would replace psychiatrists, but certainly could augment care and access, work alongside of them, sometimes unlikely on their own. But if it was a well-structured program with high quality training, demonstrated outcomes, they could, in fact, I'll say should, be able to serve in all sectors of psychiatric care, to include ambulatory care settings, county mental health care settings, inpatient settings as well. As such, I really think a recognized certification would be required in order to be able to demonstrate and afford that sort of confidence to the hiring agencies. I suspect a majority would remain in the primary care setting. If you look at, it's interesting though, if you look at, there are a few dual family medicine or internal medicine psychiatry residency programs. The vast majority of those dual trained physicians actually practice predominantly psychiatry. Almost none of them do a psychiatry embedded primary care practice like I do. I'll just say previous barriers to this or perceived barriers from those I discussed it with included sort of many assumed there would be a low interest from PCPs. No one's going to want to do that. We're not going to build a program no one's going to do. Resistance from psychiatrists, quite frankly, to support any official certification program. Everyone I spoke to in attached to psychiatry residence says, yeah, no, absolutely you should do that. But absolutely no certification that would give you any ability to do anything different than you already do. So no way of demonstrating adequate training to allow you to embed your skill set and practice into the broader practice environments that I think are needed, especially in rural settings. And also educational institutions had a perceived sort of, I would say, challenge in visioning some sort of structure to create this pathway for training. Funding would be a challenge. Who's going to put the time into doing it? Who's going to build the curriculum? How are we going to outreach? Who's going to oversee it? And that's a real challenge that maybe the state can step in and assist with building. So that's what I got for you. I don't know if there's any questions or what have. I can make stuff up as we go.
Can I just add something in, Dr. Weiner? Because I feel like I can, because
Sure,
you're
yeah.
my boss. One thing that Dr. Weiner and I have also seen as a barrier is that we need expansion. If we were to do this here at Road Community Health, he and I both have a passion for, education, training. We have to have access to expanding our available facility so that we have the room to do that. And I think if I understood correctly, oftentimes the grants don't include options for expansion. And here in Southern Oregon, when we discuss some of those millions of dollars that are already earmarked, that was a lot of up north, beds up north, expansion up north. We are desperate in Southern Oregon for expansion so that we can promote things like training opportunities, partnerships with OHSU and other, educational opportunities. We need the expansion possibilities. So, we have to have some availability. If we've got a good idea and we're gonna do it, we got to have the money behind it, sort of thing. I hope I'm not overstepping, Dr.
No, I would suggest that's exactly right. I mean, without sort of capital expansion funds, we're facility challenged right now. We don't have the space to do it. The training, or quite frankly, or the care. We can't add providers. We're bursting at the seams, and the funds just haven't been there. But we're as everybody knows, we're all struggling financially to just keep the doors open and do the basic. And so, how do we expand? So these capital expense grants would be. Many of the grants have been so limited in what we could do with them that they didn't offer great value.
Thank you so much, Dr. Dion. We have a couple more presentations that I want to make sure we can get can fit in. So if there are additional questions that you specifically, if people want to email them to Chad, that would be fantastic. Really appreciate you. And thank you for coming on short notice. And your enthusiasm is just fantastic. And so now I believe that I'm turning it over to Dr. Tyler Chipman. Chipman? Is that how I'm saying it? Who is the director of the Psychiatric Nurse Practitioner Program that we've been hearing about at OHSU. And we'll talk a little bit about best practices.
Thank you. It's funny, I'm actually looking down here to-do list, and on it says email Dr. Weiner. So I promise I will take care of it. I will reach out. Good afternoon. Thank you for welcoming me today. I'm very excited to be here. My name is Tyler Chipman, he, him pronouns. I'm a psychiatric nurse practitioner, and as mentioned, the co-director of the PMHNP program at OHSU. I just want to say quickly that Dr. Jetmalani's sentiments about the prescriber label and the relational nature of our work and meaning found in connection are just so very important. And I just thought that was a really great presentation. So I'm going to share this slide deck. Hopefully it works to tell me. Can you see it?
Yes.
Okay, great. So I want to begin with just some quick acknowledgements. First, Director Prusak, Rachel's really celebrated the launch of this initiative with me, and it's thanks to her that I have the opportunity to share this work with you all. So I also want to recognize Clarissa. I spoke with Clarissa in preparation for presenting this work to you all. And, as a rural PMHNP, she represents exactly what we are working to build through this initiative, boots on the ground clinicians serving rural Oregon. I also just want to take a moment to honor the council itself. Your dedication to protecting the interests and rights of Oregon's most vulnerable communities is essential. And frankly, it's what sets the stage for projects like ours to thrive. For me, this is not just a programmatic effort. It's a deeply personal endeavor. I think it is true that often very personal experiences lead us to pursuing positions of advocacy and care of vulnerable people. And that is certainly true for me. Professionally speaking, I've spent the bulk of my clinical practice in federally qualified primary care clinics. And what I witnessed there, as so many of you I'm sure have, are individuals struggling primarily with a syndrome of a difficult life. Incredibly resilient people doing the very best they can with what they have, and yet profoundly impacted by intergenerational trauma, understandable and yet dysfunctional means of coping, and limited health literacy, but also by trying to navigate a shockingly broken and complicated health system with very limited access to resources and culturally responsive care. So the project that I'm here to talk to you about aims to move the needle on some of those issues, the ones that are dynamic and not static at least, and contribute to the building of an Oregon behavioral health workforce that is more diverse and better distributed and hopefully sustainable. I actually recently read the talent assessment report. Let me back this up a bit. And so you as a council already know the challenges, so I won't go too deeply into them, but all 36 counties in Oregon are either designated as a medically underserved geographic area, have a medically underserved population group, or have a specific facility with a mental health professional shortage designation. And as a state, we rank very near the bottom nationally for mental health access and outcomes across all age demographics, but in particular for children and adolescents. And certainly the maldistribution of providers, lack of diversity in our workforce, and shortage of clinical preceptors are all important compounding variables. So that's the backdrop for our project. IMPACT is an acronym. It stands for Improving Mental Health Professional Access, Collaboration, and Training. That's the title that we've given to this initiative. It is funded by the U.S. Health Resources and Service Administration, and more specifically by the Behavioral Health Workforce Education and Training Grant. The purpose of the IMPACT initiative is pretty clear. It's to increase the supply of PMHNPs, to improve their distribution into rural and underserved communities, to strengthen the pipeline for students who are more diverse and will ultimately become a workforce more representative of Oregonians, and to expand the number of clinical preceptors and training sites that can host them. So here's how we are doing it, not just in broad strokes, but in concrete steps that are already underway. IMPACT is building partnerships and expanding placements. So we're embedding students at Multnomah County Health Centers and Virginia Garcia Memorial Health Center with at least a couple of students per year at each site in school-based and integrated primary care clinics. We are also expanding clinical placements in urban underserved clinics in Portland and in other rural high-need communities statewide with targeted recruitment and training of preceptors. We're aiming to expand placements with agencies serving children, adolescents, and young adults, including Collective Care Clinic and NARA. One of the goals of this project is to double the percentage of students in our program who have a primary interest in working with child and adolescent populations and providing clinical placements that principally serve that population. We do provide the clinical placements for the students in our program. In addition to that, We are working with the Oregon Health Education Center, so AHEC, to increase engagement in the AHEC Scholars Program and to develop pathways for job placements in rural Oregon with the goal of building employment connections from training into long-term practice. So impact is really built around integrated team-based training. So at Multnomah County and Virginia Garcia sites, we are designing team-based models where PMHNP trainees are precepted principally by a licensed behavioral health provider, but really follow the patient in their journey through integrated or collaborative care provision. So this means that the trainee will be exposed to brief solution-focused behavioral intervention, addiction counseling, medication-assisted treatment, psychotherapy, psychiatric assessment, and psychopharmacologic intervention, and also direct consultation with primary care. The idea here is that this model helps students to get a training experience that's more representative of their full scope of practice, allows them to have a greater degree of utility and value add for the clinics in which they are actually training, and to hopefully model the impact of embedded specialist consultation on primary care provider confidence in the treatment of psychiatric conditions, because, after all, they are the ones providing that care to the bulk of the population. In addition, OHSU PMHNP faculty will provide twice yearly in-services for primary care providers in those clinics on what they identify as the highest need subject matter. As the models of training develop, and we are kind of building the plane as we fly it, which is, it's okay, we're excited about that. But as those models of training are refined, we will be aiming to replicate them at other high need sites, starting with Orchid Health and Collective Care Clinic in year 2. Okay. So clinical training is built on a didactic foundation. And so this project is also addressing curriculum development. We are restructuring our program of study to add more robust required coursework on rural and telebehavioral healthcare delivery, and that will launch in the fall of next year. As a condition of the grant, every trainee stipend recipient will gain telehealth care experience as a part of their clinical training. And our project will support clinical partners with provision of new preceptor resources and best practice guidance on telehealth care delivery as well. We're also revisiting existing courses to integrate team-based interprofessional care models to make sure that students are being well prepared for not only their training experiences, but also building their appreciation for more innovative and effective models of care. These course revisions will be made in alignment with culturally and linguistically appropriate service standards. Student support is foundational to this work. The award amounts to about $2.4 million over 4 years. So it's just about $600,000 a year with continuation subject to ongoing approval. More than 50% of those dollars must go to students. So each year, 10 students in their final year of training will receive stipends as impact scholars. This reduces financial barriers for them at the most intense stages of their training. The final year is particularly relevant to this project for a few reasons. These students are very close to being capable of independent practice, which makes them well-developed resources for the communities and systems in which they will train. There has to be value add for the systems that are training them. Also, exposing students to high needs environments and communities as they are thinking about employment increases the likelihood that innovative positions may be developed, that they will be offered, or that existing positions will be offered to them, and that they will hopefully accept jobs in the areas that they are needed most. Did I see that somebody has a hand up?
Yes, just a friendly 1-minute time check.
Yeah. 1 minute? Oh dear. Okay. That feels tight. Okay. One sub-objective of impact is to review and revise our admissions process as well. So we're going to be doing that. And we're providing some individualized support plans for self-identifying students, trying to develop toolkits and building peer mentoring programs. Peer supports or preceptor supports are critically important. It's been talked about that clinical preceptorship in the community is a significant barrier to increasing enrollment for us. And, you know, clinical preceptorship is primarily a goodwill activity. And so part of what we will be doing is directing some of this funding towards incentivizing preceptorship with stipends and providing written resources and guiding preceptors in the unique partnership that we're trying to establish with them. With only 1 minute, I guess I've got a couple more things to say. OHSU, you know, I want to talk to something quickly that Director Prusak mentioned, which is that OHSU is currently at least the only educational institution in Oregon producing trained PMHNPs. More importantly, trained PMHNPs who overwhelmingly remain here following graduation. 90% of our students have taken jobs in Oregon following graduation in the last 5 years. Because we have very tight relationships with our alumni, we are also by extension a critical pipeline for the preceptor base in the state. So if we are effectively recruiting and graduating a diverse student body, funneling those individuals into the highest need communities and utilizing them to train additional students, ideally over time we could shift the shortage and the maldistribution and the representation of PMHNPs in the state. I hate to cut it short, but it seems like I'm going to have to. This is just a slide quickly that I just want to point to the fact that a lot of the goals of this grant complement and don't duplicate the broader workforce strategies that are being put forth in Oregon. My hope is that you see that the project is answering your call for those solutions. So that's it. Thanks very much.
Thank you so much. And similarly, if folks have questions they want to email to Chad, that would be fantastic. I just want to be able to try to fit everybody in, so thank you so much. Lastly, Dr. Mandy Hudson from Trillium Family Services, the Corvallis campus, as the Assistant Professor of Psychiatry and Behavioral Medicine at Western University of Health Sciences and Chair of the Oregon Wellness Program Executive Committee. Dr. Mandy, you're ready to present on best practices. Thank you so much for being here.
Great. Thank you so much. And thank you for inviting me. Thank you, Clarissa, especially. Really appreciate it. I have some slides I will pull up. Let's see. You can all see my presentation. Okay. All right. So some of what I plan to talk about has been covered, but so I'll go through those things quickly, but I just want to share a little bit about my personal journey. So I didn't grow up in Oregon, but I did come to Oregon for my undergraduate school. I went to Willamette, and then I did medical school with Western University of Health Sciences, the College of Osteopathic Medicine of the Pacific, actually in Pomona, because Comp Northwest was not a campus yet. However, they were starting that, and they had the Northwest track. So I did my first 2 years down in California, but then came up to the Corvallis area, was placed in Corvallis for my clinical years. And I really honestly didn't know anything about it. And so through that, I have stayed to practice psychiatry in the area. My husband's also a physician. We came up here together. He's a cardiologist now here and is the program director for the cardiology fellowship. And so I just share all of that to highlight that training people here works to get people to stay here and practice medicine here. So a little bit about why I've stayed in the area and why I've stayed happy with the work that I do. Because I like Dr. Weiner said, he loves his work. I love what I do, and I feel really lucky to get to do it. So a big part of why I stayed were the residency, that there's a residency program here. The residency program in Corvallis is in a smaller community with an affordable cost of living and provided a good community for my growing family. And that was really important. And so that was a big reason why we stayed. Other reasons that I've stayed in my position that I'm in with Trillium Family Services, there's been flexibility in my work schedule. I'm able to be a mom and a physician. And I've been able to flex that and adjust it as, my babies were little and now they're big and, been able to work through that. I feel fairly compensated for my expertise in my work, and that's important. I think that we have to offer competitive salaries to get people to stay. Others have talked about this, but the opportunities to teach both medical students and residents without feeling like it's taking away from my personal time or my salary. Because, when we teach, it does take time and time is money, especially when, physicians are paid based on production. So that's been important. And maybe most important is the supportive team. I'm surrounded by supports, and I'll talk about this more in a bit, but that keep my job sustainable, fun, and doable in a way that feels ethical and satisfactory. Basically, I get to feel really good about the work I'm doing every day. We have a trauma-informed model, which I think really helps. It's collaborative, and again, that flexibility. So next, I'm going to talk about some of the things that I've identified as challenges to psychiatrists in general. One challenge is the support services and the team. Many psychiatrists feel like they're operating in a vacuum or a void. It's really important to psychiatry that we're able to work with care coordinators, case managers, therapists, mental health nurses, and medical assistants who are, again, trained specifically with mental health. And so that can be a big challenge when those supports aren't available. High turnover of all of those other positions is also really hard. When when I'm working with a new therapist or a new nurse, there's a lot of training that has to happen, and retraining is draining, and that creates burnout. We also feel like, if we're working with a therapist, you get 9 months in and then they leave, it can be diminished gains with our shared patient population. If that patient has to start all over then with a new therapist, it's diminished gains overall for what we do. Lack of community resources can also be really difficult for psychiatrists when there's a decreased behavioral health supports in schools. And I mean expert behavioral health supports. I think that's important to state. This leads to many unsolvable social needs. So that increases the demand on the psychiatrist, who's also facing other increased demands. And I'll talk about that next, which leads again to that burnout and that moral injury. And it also leads to fewer patient hours. And because psychiatrists say, well, I can't do this full time anymore. It's too much. And so they'll go to part-time practice or leave practice or only do telemedicine. And maybe not even work to see patients in Oregon. They might be get licensed in other states through these telemedicine companies, and not even serve our state's population anymore. Another challenge is documentation and insurance. So documentation standards have just, in my opinion, gotten ridiculous. The amount of extra stuff that has to be put in our documentation. Even, I've been practicing now for about 12 years, but when I first started residency training, we were, old school with paper charts, but documentation was quick and it was straightforward. And now it's just really overburdensome. Also, the whole insurance industry. I mean, I'll get prior authorizations to fill a prescription for a patient that costs $5. Like, we're talking generic Ritalin, for example, which is absurd. And so it's paperwork and it's time, and it's annoying. It's like those little annoyances that pick at you. Also, the increased corporatization of medicine, which leads to less control or less agency, as someone else was talking about, over one's day-to-day work and workflow. OHSU did a study where they surveyed a whole bunch of physicians, and what they found was that the biggest thing that helped physicians to feel satisfied with their job, and this wasn't just psychiatrists, but physicians in general, was control over their day. So they can practice how they want, they can see the patients they want. If they want to add a patient, they can. If they want to, shift things around, they can. And it wasn't being overburdened necessarily by the amount of patients, but it was control over one's day. So all of these things lead to decreased time available to work with patients, and that's what we're here to do. That's what I think gives most of us the most satisfaction. So what are some of the solutions? I think we need to look at increasing the number of skilled workers that support what the psychiatrist is doing, and that's through social workers and therapists. And so we need to pay our social workers and our therapists well. Like, bottom line, they need to be paid better. I think we also need to look at licensure and streamline that so that it's not complicated and doesn't take quite so long, perhaps. I don't think we need to be trying to replace master's level social workers and therapists with lesser trained staffing models just because it's quicker and cheaper, because that just increases the burden on that top licensed person, which in this case would be the psychiatrist. If I am having to supervise somebody who isn't trained as well, that's a bigger burden on me than probably just doing it myself. So we need to, I think, be careful to not say, well, we could train a whole bunch of bachelor's degrees to do the work when that's not probably going to be adequate. I think we also need to increase private insurance and Medicaid and Medicare reimbursement for therapy. Therapists can go into private practice with a cash pay only model and make a whole bunch more money than billing insurance with a whole lot less headache. So I think we need to look at that as well so we can keep people working. We also need to help the helpers. We need to support programs that take care of the mental health of behavioral health care workers and healthcare workers. Access to expert mental health care is dismal, and it's as dismal for us as it is for the general population. Physician suicide rates are 2.5 to 3 times higher than that of same age peers. And we really need our healthcare workers to have immediate access to expert mental health care. We can't be waiting 6 or 9 months to get in with somebody. So I am going to put in a plug for the Oregon Wellness Program, which serves serves healthcare workers in general. It's 100% confidential. It's free of charge. There's no insurance billed. I threw some numbers in for how many it's serving. But I think the biggest part is that the people who are providing the services, the therapists who are providing the services for our healthcare workers, are experienced with healthcare professionals. And so they know the burdens and the special population. Also, they're committing to seeing these people within 3 business days of initial contact. That's huge. That is like a gift from the heavens being given to our healthcare workers. And so the demand for this program has increased exponentially. The financial support has not been able to keep up with the demand. We did have a Senate bill that unfortunately was not funded this session, but I am throwing out a plug that we need to help our helpers, and this is a fantastic way to do that. All right, a couple of the numbers in the state. So I don't know, how many of you know there are 2 medical schools in Oregon? There's Comp Northwest, which is in Lebanon, which is a very rural place and really expertly training people to practice rural medicine. And then obviously OHSU. There are 2 psychiatry residency training programs in Oregon. OHSU, we've heard about. Samaritan Health Services in Corvallis, Good Samaritan Regional Medical Center also has a psychiatry training program and also has a child and adolescent fellowship program. So we know that many physician trainees will stay where they completed their residencies. And this is important. I think an important distinction between the psychiatric mental health nurse practitioners is that because they don't have a residency program where they're doing their initial schooling, they will stay. For physicians, they'll stay close by where they did their residencies. So, if we want to increase the number of psychiatrists or any physician specialty in Oregon, we need to increase the number of residency positions, especially in rural communities. Bottom line. Taylor, are you giving me my 1 minute?
Friendly time check, yes.
Okay, I'm getting there. I'll be there. Thanks. So I just want to state, like, really hone in on this, that we need to increase the number of residency positions if we want to increase the number of psychiatrists in the state. And that can't just be in Portland. We really have to look at the rest of the state. And because practicing psychiatry in Roseburg or practicing psychiatry in Klamath Falls is going to be very different than practicing psychiatry in Portland. So, I think we need to look at diversifying where our residency positions are. All right. Again, increasing the psychiatry residency positions, and it's not that there's a lack of medical students who want to be psychiatrists. Psychiatry is one of the more desired and competitive specialties for medical students these days. And all of the students who want to become psychiatrists are not getting into psychiatry residencies. And so that tells us we could have more psychiatrists, but we have to have those residency spots. And that's a national issue. But I think we could do that in our state because we do have 2 medical schools with more than enough people who would like to become psychiatrists. We also need to support psychiatry residency training through increasing our psychiatric inpatient beds, both adult and child and adolescent. We have to have inpatient beds in order to have training programs. One of the problems that has come up in Corvallis is that we have there's been a very big reduction in inpatient beds at Good Samaritan. That really hurts the training program. And so those trainees are having to go to Portland again, so then now they're losing that more rural training that we're trying to do. And so we need to have state support for our hospitals to increase psychiatric inpatient beds, or we can't have training programs. All right. We've talked about this a little bit. Student loan or payment programs with bonuses for those practicing psychiatry. Again, I think Jet Milani went over the medical school debt, which is a lot of money. Also, public jobs like county mental health must compete with private sector jobs and private practice through pay, flexibility, student loan or payment, dedicated administrative documentation time, and support for administrative burdens. All right. I'm there. It's like one more slide, I think. Support. We also need to support flexibility in practice in order to keep physicians in practice. Just really quick, majority of medical students are female and will be of childbearing age in training and as in new grads. So we need to have supportive environments that allow for family care responsibilities, both financially and with flexibility. And then we need to allow flexibility in hours. Some people want to practice telehealth some of the time, and we need to be able to compete with these national telehealth firms that are offering big bonuses and tons of flexibility and those sorts of things. All right, legislatively, reduce documentation payer requirements, reduce payer prior authorization, denials, peer-to-peer burdens, all that stuff that doesn't let us do what we need to do to take care of our patients. All right, that's it. I threw my email in there, phone number. Please feel free to be in touch at any time.
Nicely done. Thank you so much, Dr. Hudson. Okay, folks, we are a little bit over. Thank you so much for being willing to stay. I know you're busy and have patients to see and students to teach. Clarissa, thank you again for helping organize this this incredible panel. You know, it's just really important that everybody understands the different facets of what these professions look like. And so I just want to just really quick, I'll remind people some couple things. Our next meeting is September 25th from 2 to 4. You'll get the calendar invitation. And then in the next coming weeks, we're going to continue to do this best practices, and we're going to have different meetings chunked out for around mental health treatment, addiction care, one dedicated to peers and then youth settings, because there are additional complications and things that go along with that. And so if there's anything specific that you'd like to recommend to this series, or people you would like to recommend, please reach out via chat and the email. And again, I also just want to say, I know people have been diligently working on their action plans, and I just want you to know that I am the governor's office, are just eternally grateful for you for spending the time to do this work. I know it comes at personal expense, and you have other things that you are doing, which is why your expertise is so important. So again, every time I see you, I am grateful. Thank you so much, and I look forward to seeing you on the 25th.
Thank you.
Thank you.
Thank you.
Thanks.